minor annoyances. 420 patients, now we're getting up to 5 axis site complications, including 3 AV fistulas, 2 pseudoaneurysms, 2 with thrombosis of the angioplasty site, and I think Don had mentioned one case that he had experience with that, 3 patients with disease relapse, 355 patients, again. In all these, as you look at these outcomes and look at these cases, the bottom line is, this is these 2 large studies I just flipped up there, it's pretty safe. Nothing's 100%, just like CCSVI and MS. And, you know, MS patients who all have CCSVI, no. I mean, there's exceptions. But in general, I think some of the potential complications have been amplified beyond, I mean, suffice to say anything can happen. And that's what I tell all patients, no matter what procedure I'm doing. You may have a contrast reaction. Stent migration, I take full responsibility for this patient. He stayed in the hospital 2 days longer than he should have. It's become sort of the poster child for the horrors and catastrophes of CCSVI treatment with stents. Whatever, if I had to do over, I probably would fish the thing out endovascularly, but I looked at the echo and I thought the best thing for the patient was to just open the atrium up and under direct visualization take it out so we don't mess around with the chordae of the tricuspid valve. That was done. He left 2 days later, but it blew up into a tremendous thing. Okay, closing. Clearly MS is a complex pathologic process. I know that neurologists tend to look at us as cowboys, kind of, you know, guys who are, you know, not cognitively inclined in any way, but I think we recognize that it is complex. But it's not unlike certain cancers, where the etiology are influenced by a variety of factors. And I think most neurologists would probably say that although they are mavens of the disease, they don't have the corner on consciousness or what causes MS. There are all these different factors, so you have to open your mind up. You can't be rigid. The precise interplay and requisite contribution of these factors that leads to MS is unknown. Everyone has an individual mosaic of etiologic elements responsible for the disease expression. And I bet all patients may have some fundamentally little different twists. CCSVI may or may not be one of these factors that promotes or enables, along with these others, the development of MS. It's like a detective story. We all know that. New evidence surfaces every week. Clues are investigated. Research may produce conflicting, supporting, refuting observations that confound, bolster, or dispel our prior notions. This is normal. This is how we move forward. This is how we advance. Pieces of the puzzle are ultimately going to be put into place. I know for all of you it's not happening fast enough, but I'm telling you, there's certain puzzle pieces that we won't understand after you put it aside, just like you're doing your jigsaw. You count a couple corner pieces, and it all ultimately gets put together to illuminate the next step that we're going to take along to a path towards better understanding of this multi-dimensional interplay that triggers the disease. So whatever the spark that ignites the fuse lead to MS, there are a number of catalysts that have the potential to accelerate the tempo of disease. CCSVI may contribute in concert with other factors in different arrays that ultimately may define subsets of MS patients. Beyond just this relapsing remitting, which I don't, you know, we follow that because that's convention, but I don't know that that tells us a lot about the disease. There are going to be new subsets that will emerge from the murk, and we'll be able to make sense of it. Thus, it doesn't bother me in the slightest when CCSVI critics point out that patients with an absent or thrombosed jugular, have had a radical neck for head and neck cancer, whatever, do not have MS. Or that all MS patients do not exhibit CCSVI. There are many routes leading to the same point. It's just one of the elements. More than likely, the therapeutic response is not an all or nothing. Similar to veno-occlusive processes involving other vascular territories. If you're an interventionist, you know portal vein thrombosis, pulmonary embolism, lower extremity DVT, we kind of make the thing better. It's never going to be factory fresh perfect, but at some point you reach some physiological compensation, whether it's a pulmonary embolus or portal vein thrombosis, that the patient does better, survives, improves. The tipping point or threshold for this therapeutic benefit is unknown for CCSVI, and that's what we have to define. Benchmarks for anatomic success are going to be difficult to define, but we will get there. And complete resolution of flow disturbances may be unachievable. Finally, just as the constellation of MS symptoms varies from one individual to another throughout the course of the disease, it's likely that the response or lack of response of these symptoms may differ between every MS patient. The exact relevance and interdependency of potential contributing factors implicated in the pathogenesis remains undefined. In any individual, the status of most of these candidates is fixed. So think about genetic, environment, I can't change your post-viral exposure history. I can't change your genetically determined immune function, how you were wired at birth. I can't modify these. But if a proven role for CCSVI is established, there exists a distinct opportunity that you could reverse that component, because we've shown that it's possible. So, in conclusion, there's been a growing understanding of CCSVI and MS as studies are performed all over the world. We're not there yet, obviously. We're just at chapter 1. It's helpful to understand what we know and what we don't know for obvious reasons, to help effectively communicate with potential patients, to make sure that discussions with neurology are balanced, and to be certain that research is directed towards answering all of these unanswered questions. Thanks very much.
Are there any questions? Please, go ahead.
I'm wondering if you see things on 7T imagery that we do to believe that there's stuff aside from the easy names that are causing issues.
The question is, with 7T clinical scanning, do you see things that are, what was it again?
Intracranial.
Intracranial venous abnormalities. Well, to be honest, as you know, I've been to that NYU Magnet, and it's in Manhattan, so that's a challenge opportunity at best. But having said that, 24 flatbed trailer trucks of steel to shield that magnet. So these things they're not like out there that we have a lot of experience. And certainly, I bet that picture I showed you of the 7T, so these are like maybe 12 patients in the world that have probably been studied. It's just not yet, and again, the reason I was there is because I used to be chairman of radiology at the University of Virginia. And we were thinking about this, and this is not just buy this thing that's off the shelf and put it in a warehouse. There's a huge infrastructure effort with coils and engineering to really get the thing to run, because as you can imagine, it's very, very different than the other magnets we have.
Yeah. So between what you said and a little bit of what Jack Berg says, I'm just a little nervous. We talked about how there's places that are collecting data, but then there's these complications. People have passed away. How do we have any idea with the places that aren't collecting data if there have been like deaths? Do they have an obligation as doctors to tell us? Are patients still going to doctors who've had an adverse event and someone died and then we don't know? I'm just sort of nervous.
I think the answer to that is I don't really have a great answer for that, except to say that certainly there does not need to be right now. There's not a sort of a clearing house for this, and that's why we would like people. But it's just like any other procedure, except for the fact that we we need to have these registries that we can capture all of that, to at least to get the denominator up to something that we can feel relatively confident and secure that if someone has had experience, this is what we can expect. We're always going to have the rogue stuff going on, and hopefully that sorts it out. Right now, it's not a comfortable time because we just aren't able to put together. It's not easy to say. We will get it done, but it's not easy to have the trials just start up for obvious reasons. Yes?
Michael, just as a corollary to that question, what is the role of community health centers as opposed to centers for excellence for understanding and propagating the usefulness of CCSVI?
Well, I think that there is a role, and I think one of the ways it can really help is in terms of establishing, not necessarily getting at the real basic science aspects of what's going on, because that's beyond the scope of most community situations. What is within the scope is to adhere to certain standardized protocols, pre-procedure planning, surveillance follow-up, because we have to stop this idea. It doesn't work to have people flying all over the world.